Good. Hello. All right. So it is week 7. Like we're over the hump. So getting closer to the end, gearing up for exam 3, which like I said, last week, you guys like rocked that exam last week. So I'm hoping and praying that we can just continue this wonderful trend, because you guys did absolutely amazing. Very proud of all of you. You guys really, I mean, I can't even say anything. Like you guys just rocked that exam. So excellent job. Very proud. Um, so for today, we are going to, just for week 7, we're going to talk a little bit or a lot about healthcare system. Um, we're going to talk about things like funding. What else? So like a little bit about insurance information, like basically, how we finance healthcare here in the United States. We're also going to discuss um, what do you like some of the places that you can work, things that you can do within healthcare as well. So lots of information that's going to be presented today. Now, some of it can be a little confusing, especially when we get into like Medicare and Medicaid, and things like that, but we're going to kind of get through it. It is chapters 15 and 16 in your Success in Practical Nursing book. Then in your Delegation and Management of Care, it's 2, 4, and 6. And then in your Concepts book, it's 48, 55, and 56. So we are going to start with obviously chapter 15. Chapter 15 is going to cover healthcare settings. So the different types of hospitals that are out there, as well as what are some of their functioning. So even though, we think of acute care hospitals, right? They're hospitals, they do their thing. Um, how they're supported, how they're funded, um, can be a little bit different, depending on the type of hospital that it is. We have public and we have private healthcare agencies, and of course, how they're supported is different. So I'm going to share my screen. All right, can everybody see the PowerPoint? All right, perfect. So, yep. All right, so here we have the comparison of healthcare agencies. Again, healthcare entities, they are all going to provide a variety of services. They're owned and operated by either public, which is the government, or private entities. They are also both profit and nonprofit organizations. And so, depending on where you live or where you receive healthcare, or just in your areas in general, you may see different types of hospitals. So, this chart is in your Success in Practical Nursing book, and it just kind of gives an overview of the different types of hospitals. So, I'm going to make this just a smidge bigger for my old eyes. So over here, you see we have public, which we have official, which are government, and non-official, which are non-official, which are voluntary. And then we have private agencies. So we'll start with just the public. We'll start with government. So government hospitals are supported by tax money. They offer programs of disease prevention and wellness promotion. They sometimes will direct services of healthcare as well. They are accountable to taxpayers as well as the government, and they will offer both mandated and non-mandated programs. So mandated programs are programs that are required for them to offer, as laid out by their oh my gosh, the government, or, what is the support there, whoever's supporting them is going to decide what programs need to be mandated. Your voluntary or your non-official public hospitals, they operate from voluntary contributions as well as fees for service. So they'll get contributions from the public. And then fees for service is, your insurance, or in the situation, some people are private pay. So however they just, however people pay for their health care. Their primary services are research and education. So a lot of research, a lot of education. Um, they offer direct healthcare services or direct health services, and they are accountable to their supporters. So those people that are contributing to them, their board of directors, and others that are responsible for maintaining that organization. And that's how those programs are determined too. So what programs that they offer are going to be determined by what the supporters are interested in. And then we have our private. So private hospitals offer a fee for, they get fee for service. So whether it's private pay, you pay for your healthcare services, or you have insurance, that's how they receive their money. Their primary services is curing illness and disease. They also may offer some disease prevention as well as wellness promotion, but they are going to be accountable to their owners. So depending on where you live, what your, what do you call it? Wherever you live, like if you look at who your hospital, like what hospitals that you have, um, they may have like a group of hospitals, that are all owned by the same organization, or you may have some private or government owned hospitals within your area as well. Um, and of course, the owners, right? They're going to be the ones that are going to determine what services they're going to offer. And they determine those programs related to what their goals are for their organization. So again, we'll go, and then we have public healthcare agencies, and these are a little bit different. Um, these are official government agencies as well. There are two types of public healthcare agencies. There are official as well as voluntary. So official, we look at local level, that would be your city or your county health department. I don't know if anybody's ever been to their health department. But they offer things, well, it depends on the area, but they may offer like, vaccines, especially if like you're going to get ready to travel outside the country, or if you're coming into the country. Um, some have like STI clinics. The one in Virginia, it used to have like a diabetic educator, and other services. And I know some of those services have been cut due to cutbacks. But again, depends on where you live and what services they have. Um, your health department is funded by local tax money. So the taxes that you pay for your city or your county, that helps to fund your health department. They do get subsidies from the state as well as the federal level of government as well. They will carry out the state laws, which are the mandated programs, okay, concerning community health. And then they may do some non-mandated programs, so like health promotion programs, or like I said, the diabetic educator, whatever they can, have locally. And then in cases of, community health issues like an outbreak of a contagious disease, then they will respond. And a lot of times other, government agencies may come in to help. So just as an example, long time ago in a galaxy far away, when I was in my bachelor's program, I did a week with the health department as far for my community health course. I spent a week, and that's how I knew about the diabetic educator, because I spent a day with her. I also spent a day with the epidemiologist, or half a day with the epidemiologist, which was actually really cool. Like I said, really long time ago, but One of the things that she was telling me about, like I said, long time ago, they had a salmonella outbreak. Um, and so, what part of her job was to investigate that salmonella because in Virginia, salmonella is a reportable um, communicable disease to the health department, or not communicable, but a reported disease to the health department. So they had to do an investigation because I can't remember exactly how many people that she said were affected, but it came back. I think the common denominator was poorly cooked chicken at a wedding venue. And so all the people that had attended that wedding had gotten salmonella from that poorly cooked chicken. So they will respond, they'll investigate, kind of see what the cause is, do follow up as well. When I worked in peds, because salmonella is reportable, we had a child come in. Trying to remember how old, little, like under 5 is basically, I don't remember, I know younger than 5. I think walking, so probably between 1 and 5, somewhere on there. Um, he came in, he ended up testing positive for salmonella. So I had to report that to the health department in their investigation. They had like a, are they like Komodo dragons? Is that what they're called? Those, they look like lizards or like really big lizards. They carry salmonella. And I guess the lizard or whatever it was like just walking around the house kind of thing and had gotten on the counter or was on the counter, and the little kid was eating food off the counter and the salmonella got on the food and got salmonella. So the little things, but again, the health department, they help with all that. They do that investigation, find out what the underlying cause is, right? So we can try to eliminate it from happening again. At the state level, we also have a state health department. The state health department is funded by state tax money. So, local health department, you have your local taxes with subsidies, your state health department, state money, but it also may receive money from the federal government as well. And then at the federal level, we have the U.S. Department of Health and Human Services. Okay, so they're like the health department for the nation. It is subsidized, or it's funded by federal tax money. The head of the Department of Health and Human Services is appointed by the president, and that person will, keep the president informed of the health of the nation and anything of concern that needs to be, that he needs to know about. And then under the Department of Health and Human Services, there is 11 operating divisions. There are 8 agencies that will fall under the U.S. Public Health Services. And so some of these are here. Sorry, I probably made that too big. You can't see the whole slide. Um, the U.S. Food and Drug Administration, really important people, do a lot of great things. They make sure that our food, our human as well as animal medications, any biologic products, and medical devices and any electronic products that emit radiation are safe and effective. Um, so obviously, food and medications, pretty easy. But think about medical devices and electronic devices that we use, right? Defibrillators, pacemakers, all of your implants, your knees, your hips. What else do they implant? Heart valves, all of that stuff. It has to go through the FDA approval process. It has to be safe for human use. Because you don't want we don't want to put something in a human that's not safe for human use, right? And then have issues as a result of that later. Then, of course, we have the Centers for Disease Control and Prevention that they provide leadership in health prevention and promotion programs. They respond to public health emergencies as well. A lot of people really probably didn't pay a whole lot of attention to the CDC until COVID, right? Then the CDC all of a sudden became a very popular website to get information. And then we have the National Institutes of Health. The National Institute of Health funds biomedical research. They have its own labs. Um, they also will fund research in universities, hospitals, and private research institutions, as well as the private industry. They also will train new researchers. They also promote collecting and sharing of medical knowledge. And they have like a whole bunch of centers underneath them. But it also includes the National Institute of Nursing Research, which is the NINR. Great place if you're looking to do a paper, future, of course, or looking, for evidence-based practice and things like that, that nursing or the National Institute of Nursing Research is a really good resource for you. And then we have voluntary care agencies. Voluntary care agencies, exactly what they say. They are voluntary. And there's a variety. This isn't all inclusive, right? This like your American Cancer Society, your American Diabetes Association, American Lung Association, American Heart Association, Alcoholics Anonymous, La Leche League. What else do we have? We have things like Alzheimer's Foundation, or is it Foundation? We have Narcotics Anonymous. We have Al Anon, which is for the survivors of alcoholics. The American Stroke Association. We have the ALS Society, right? Could probably go on. There's numerous voluntary healthcare agencies out there. Um, and these are also really good references, not just for you, but for your patients. If you have somebody that has cancer, has diabetes, right, has a heart issue, a lung issue, or, is an alcoholic, we can refer to these agencies as well. They have websites with lots of great information on those websites that can provide education to your patients and resources, like if you have an alcoholic that needs to know where there's a meeting locally, right, they can go there and they can find a list of open meetings. All right, so we'll get into the private healthcare agency. So most of you probably know um, a little bit, be a little bit more familiar with private healthcare agencies, because this is usually where we, gain entry into healthcare. Um, they can be either proprietary or nonprofit, meaning they charge fee for service. And nonprofit, they often, right, take donations and things like that to sustain their organization. They usually focus on curing disease and illness. Of course, more recently, within the last few years, there is a greater emphasis on disease prevention and wellness, right? Because if we can prevent disease and keep you healthy, right, in the long run, that's going to decrease healthcare costs, right? You won't need to use as many services. And so we really want to put a big focus on prevention and wellness. And again, like I said, most people get their healthcare through private providers. So if you have a primary care provider, right, they're the ones that usually direct that care. Family practice physicians do primary care. And then they'll refer to specialists if you need additional evaluation, right? Which is something that, is a little bit different than how, healthcare used to work, right? Your primary care used to manage a lot more of even chronic diseases. In some cases, they still do. But a lot of times, what your primary care will do is that initial assessment and evaluation, and then determine what other services you need. So, if you need orthopedist, a neurologist, an endocrinologist, a nephrologist, whatever, they're kind of the ones that are going to, right, send you out and try to help you navigate that process. But yet, all that information that is, you say you go to the orthopedist, they're still going to send reports back to your primary healthcare provider, right? So that they have it all kind of there in a central repository. Private practice nurses, Private practice nurses are advanced practice nurses who counsel people on healthcare issues. They fill an acute need in rural areas where physicians are sometimes difficult to obtain. So think of your nurse practitioners. We know that the laws have recently changed in regards to how those advanced practice nurses can function. And so of course, depending on what their Nurse Practice Act says and everything. But in those rural areas, we think there's not a lot of healthcare providers that are out there. They are an absolute necessity so that people can have access, right, to somebody that can manage their care or even direct their care to try to get them to the specialist that they need. Am I going too fast? I feel like I'm talking really fast. Um, All right. So then we go into the different types of hospitals. Okay. So we have community, we have federal or state, we have voluntary community, and we have critical access hospitals. All kind of in a roundabout way, they all really kind of do the same things. Um, just really depends on where they're at and we know what service. Some of them will offer different services. So when we look at community hospitals, they will usually provide wide range of medical services. However, with community hospitals, they may not always have the specialists for those serious conditions. So you may have to be referred either, to another hospital or another provider, depending on what is available at that general community hospital. We also have specialty hospitals. And so specialty hospitals offer services related to a particular disease. They have very highly skilled specialists with advanced knowledge to treat whatever that, specific disease is. So you may see things like trauma centers. That would be a specialty hospital. OBGYN, ENTs, rehab hospitals where we have acute rehab hospitals. Yes, we have rehab facilities within like long-term care facilities, but there are also actually specific rehab hospitals that offer a little bit more intensive rehab for people that need it. It could be an orthopedic hospital. It could be a variety. So like you may have like a hospital in your area, they may have like a special like orthopedist hospital or orthopedist unit or orthopod unit within that hospital, right? Or a trauma center or the OBGYN, right? Those are your specialty hospitals. Trauma centers, they have to be able to offer specific services, and that is how that they are rated. Your voluntary community hospitals, these are either community associations or religious organizations that operate these. They are nonprofit, and they provide short-term inpatient care for those with acute illnesses and injuries. These are heavily dependent on gifts and donations to supplement their revenue. And so the ultimate responsibility for the hospital will obviously be with the board of trustees, but they also will have a paid administrator that kind of just oversees and manages the hospital for that day-to-day basis. Um, and so with your, religious organizations, trying to think of one, like Bon Secours in Virginia, I know is a religious organization that has a couple hospitals. Other types of religious organizations that you meet. Has anybody heard of like Shriners Hospital? Yeah, so like just think of, they're always on TV, they're always doing telethons, right? Trying to raise money to support the services that they offer to those kids or adults in some cases. And then your public hospitals. Public hospitals, these include things like the VA hospitals. So anybody that's a vet uses the Veterans Administration. It could be state, county, or municipally owned. Nonprofit hospitals It could also be those hospitals for people with serious mental illness. Those are funded by federal, state, or county funds. So think of like your local or your state psychiatric facilities. Oops. Um, Sorry, my mouse went a little bit crazy. And then we have teaching and research. So teaching and research hospitals, they are either community or federal government hospitals. They are also training sites for healthcare professionals. So nurses, doctors, other healthcare providers as well. They also will, teach clients or treat clients with serious or unusual conditions. They do a lot of research and develop treatment development. They'll do clinical trials. They are usually always affiliated with medical schools. So like Vanderbilt and John Hopkins, Boston University Hospital, just to name a few. There's many more out there. Okay, those are just the ones that kind of popped into my head. Um, but you have access to highly skilled practitioners in these hospitals. Some of your VA hospitals or military hospitals too are often teaching hospitals. For them, they train, right, their medics or whatever service it is, whatever they call them, foremen, medics, within those hospitals, and even some new providers. Because, even if they graduated from med school, right, and they join the military, they still have to do their internship, their residency, and things like that. So they get training within those hospitals as well. And I don't know, it does, like, I hear it all the time on TV. Like there's always, and I guess it depends on what your area is, but here on the radio and on the TV, there's always recruiting for clinical trials, right? They may have they'll put a commercial out there, do you have this? Or, they're looking for, healthy people with eczema or otherwise healthy people with asthma, right? Looking to try different medications. And of course, it's strictly voluntary. Nobody can force you to conduct, to be part of a clinical trial. But depending on the area you live in, you may hear some of those, especially if there's research hospitals in that area. With critical access hospitals, they're small hospitals. There's no more than 25 inpatient beds. The average length of stay is usually not more than 96 hours. But they still will offer, the 24 hours, 7 day a week emergency care. But these are located more in your rural areas, at least 35-mile drive away from any other hospital. So in emergency situations, right, the goal there would be to stabilize the patient if it was, a trauma or something like that, and then transfer them to a larger facility if they should need any additional specialists. But generally, your critical access hospitals are going to care for more common conditions. They may have some outpatient care as well. But again, these are more like in those rural areas, just to make sure that they have some access to care. And then ambulatory services. So these ambulatory services, think of, you know, a lot of your, outpatient services, the number of inpatient stays, length of stay in acute care facilities have decreased. And, the goal is to get them, stabilized and discharged as soon as possible. So providing ambulatory services is a little bit less expensive, because we don't have to admit them to the hospital. And, this could be very similar to, even using some of your specialists and things like that. So there could be an outpatient hospital, it could be a nursing care center. It could be your primary care providers or your healthcare provider group practices, HMOs, specialist office. They could be freestanding ambulatory centers. Urgent care centers would fall under this as well. Um, Again, these are often less expensive. Like it's a lot cheaper for you if it's not something that you need emergency room for you to go to an urgent care, right? You have flu symptoms. You sprained your wrist. You cut your finger, right? You need stitches. You can go to an urgent care. Again, usually a lot less expensive. And these, of course, are for people that live independently or are cared for at home. They can do assessment, they can treat, they can also do care coordination as well. Um, some of your outpatient clinics. So let's say you have that patient, right? Patient gets admitted because they're having a heart attack. They get admitted to the hospital, they're stabilized, they're treated, they're getting ready to go home, and they are going to need follow-up once they are discharged. So we have those outpatient clinics. So they can manage diseases on that ambulatory basis for those that don't need to be hospitalized or have been discharged from the hospital. It can be freestanding. So, there's doctor's offices everywhere, right? They have freestanding offices. Some of them are attached to healthcare facilities. So, like, you may have like the main part of the hospital where your inpatient is and all of the ancillary services within the hospital, and you may have another building next to it that has doctor's offices in it, right? Depending on where you live again. Um, so it just depends. Um, Appointments are generally needed in outpatient clinics, right? You need to go see your cardiologist, you need to see your nephrologist, your orthopedist. Generally, you're going to make an appointment to go see them. Um, so again, usually variety of services, depending on what the specialty is that the person needs, they generally can find one. Now, not every area is going to have every specialty. However, for the most part, people, and especially in the cities and the more urban areas, generally can find the specialists that you need. It's the rural areas, right, that we really worry about what specialty needs. Urgent care centers. So services, of course, we can, they provide services for walk-in clinics. Although I've noticed that, and I don't know how true this is, that some urgent care centers, you can actually make an appointment and be like, you can schedule an appointment, like either calling, I guess, I don't know if it's calling them or scheduling it online, but you can actually schedule appointments in some of the urgent care centers, which I think is cool. I don't know if it helps with the wait times or anything, but I thought that was interesting. A lot of people will use urgent care centers as primary care providers. If they don't have a primary healthcare provider, like a doctor that they go to for their normal everyday stuff, a lot of people will use urgent care centers. And so there's a variety of different ones out there: express cares, quick cares, urgent cares, convenience clinics. It's even like, I forget, what do they call it? SCBS, it's like the minute clinic or something like that. I've never looked to see what services like CVS has. I have used CVS, like I've gotten in like my immunizations through CVS, but I've never looked at like what other services. I also thought this was pretty interesting. So when I moved to Texas and trying to find out like a primary care provider, the Walgreens. So I haven't actually, I'm not gonna lie, like the one by my house, I haven't been in. It still has like the pharmacy. I don't know if it still has like this, how you can go to see, I mean, you go to like Walgreens, right, for anything, use makeup and whatever, toiletries and all sorts of stuff. But all the Walgreens they have, so like I said, they still have the pharmacy, but they're all doctor's offices now. Like I was like, what happened to Walgreens? So, instead of actually being like a drugstore, convenience store, it's actually providers' offices. So I thought that was pretty interesting, and they're like all over the place down in Texas. Um, so I'm not sure. Like I said, I haven't been in one to see if the actual store part is still there or if it's just the provider's offices. but I thought that was pretty interesting. It was something new for me. Um, 1 day surgical centers. So 1 day surgical care centers are what we call ambulatory surgery centers. They perform surgeries at a scheduled date and time. So let's say, gotta have your tonsils out. Okay, you can schedule an appointment. They'll schedule you. You'll go in. You'll get your tonsils taken out, and then once you have recovered from anesthesia, you're considered stable, right? You go home, right? So it eliminates the need and the charge for having to stay in the hospital overnight. So again, a little bit cheaper cost. And these also variety. So there are freestanding ambulatory surgery centers that are separate from the hospital. Now, some cases may be on like the same campus as a hospital, or they may be completely separate. In some cases, they are often in hospitals as well. So, like if you go into a hospital, you may see like got the directory, you may see same day surgery or ambulatory surgery center. That is generally for people coming in to have a procedure and then going home. Whereas your inpatient surgery would be patients that are admitted to the hospital, have to have surgery, and then are going to generally be staying in the hospital, whether it's overnight or for a period of time. So it really just depends. The ambulatory surgery center is not going to do complex procedures, okay? So you're not going to go and have open heart surgery in a 1 day surgery center, right? Because you're not going home that day. You're going to be staying in the hospital. So again, it's for like just minor procedures, like I'm trying to think. So like my daughter had her tonsils taken out through ambulatory surgery. Trying to think of what else. My husband actually had ear surgery through ambulatory surgery. So you go in, whatever your scheduled time is, you get your pre-op, you go in, you have your procedure. And once you're done, you wake up from anesthesia, you're stable, you go home at the end of the day rather than staying overnight in the hospital. Free clinics. So there are free clinics that are available as well. Some of them are free, some of them are reduced fee clinics. Again, this is another alternative means for primary health care. So most of them offer services for people who can't afford traditional health services, or they don't want to use the traditional health services. Most of them will have an age and or an income limit. They are usually staffed by a salaried administrator and then volunteer healthcare providers as well as nurses. And then they have a volunteer board that makes the policy decisions. So again, depends on, the population, the availability of your, volunteer staff as to where these facilities are located, how many of them there are available in the area. Um, because again, it is voluntary. So if people are working full-time jobs, right, and they're trying to still volunteer their services. But these offer, again, like I said, a lot of them do have an age or an income level limit. Some of them are more centrally located, others are not. So finding information about free clinics, especially to patients that don't have health insurance or are very low income, right? Knowing what free community services are available for them, especially if they're leaving the hospital, is something that we should research. And then we have our community-based care. So skilled nursing care. Skilled nursing care. So skilled nursing is available within a long-term care facility. In some cases, it also can be made available through home health, depending on the patient's needs. The long-term care facilities are designed to help people who have disabilities and chronic medical needs. So there has to be a medical reason for admission into a long-term care facility. Can't just check yourself in, say, I want to live here now. There needs to be medical need. Skilled care is a little bit different. Skilled care is considered care that's medically necessary to improve the quality of the client's health or maintain or slow decompensation of a client's condition. So, physical therapy and occupational therapy after a hip fracture or a knee replacement, after a stroke. Then we would add speech therapy. Trying to think of what else. Um, Hips, knees, cardiac surgery. Or even somebody that has a severe infection like sepsis or MRSA, and they're on IV antibiotics, right? They may need to, they qualify for that skilled care. In some cases, we'll put them in a skilled care facility while they are receiving their IV antibiotics to make sure that they're getting their antibiotics and providing care to that IV, right? So we'll have like a PICC line that'll need dressing changes, make sure that it remains intact and that there aren't any issues with it. With alternatives to long-term care. So, promise you, it's not everybody's goal when they get older to live in a long-term care facility, okay? And even patients that have had hip and knee replacements, right? The thought of having to go into a skilled facility can be a little scary. But there are alternatives. Home health is one of those. They primary focus of home health is relationship centered care. So it's not just the client that we're working with the family as well, and within that client's environment, so their home. The client does have to be homebound and required skilled care. Okay, so whatever the skilled care service is, and we'll talk about that as well. But the purpose is to promote, maintain, or restore health or minimize the effects of illness or disability. So a lot of education is done. Home health nurses, one of the main goals is to teach that client and that client's family how to care for them, care for the client, how to care for himself or herself. So there's lots of education. It is directed by an RN case manager, but home health, they can do skilled care. They can do PT, OT, speech therapy. They can do social services. They can offer even like CNA or home health aid services. It depends on what the needs of that client are. And home health can be public, it can be nonprofit, or it can be for profit. So it really kind of just depends. There's lots of different organizations that offer home health, like some of the hospital systems may even have their own home health agencies that they have, to refer their discharged clients to. But this is what skilled nursing services are. So these are services provided and directed by an RN. Basic nursing services would be provided by the LPNs under the supervision of the RN. Depending on state regulations and agency policies, LPNs are able to provide a lot of the home health services that that client will need. But again, the goal is to get them back to anytime anybody's sick or has an injury, a trauma, something, our goal is to try to get them back to their previous level of functioning, or at least as close, to their previous level of functioning as possible. Everybody will have a treatment plan that's signed off by a healthcare provider. And so some of the skilled care services, obviously teaching, supervising, administering, or preparing medications for self-administration, giving injections, glucose testing, helping them to create a safe environment is another big one. May have to do treatments like ostomy care, wound care, bowel and bladder retraining. They may even require oxygen or respiratory care as well. But anybody want to do home health when they graduate? Kishari, yeah. Are you doing it
Do what?
now or
Yes, yes.
do you like it?
Yes, I do, because I did nursing home care before.
Okay, so you like home health versus nursing home? Well,
Yeah,
I
and I feared the hospital, and maybe I should give it a try.
see that's funny. Yeah, I never wanted myself. I never wanted to work in a hospital. I'm not sure why, but so I thought about doing home health, but yeah, I don't know. I can't go into people's houses like that. Like, I feel like, don't laugh, Kishore. Um, I guess there's a couple of reasons. Like, one, I feel like I'm invading somebody's privacy. And two, my face says a lot. And I'm trying really hard to work on my face. But my face says a lot. But when we go into people's homes, right, we're there to provide a service for them, whether it's a healthcare service, whether it's making sure that their environment is safe, and clutter, just and things like that. Like you never know what your client's house is going to look like, right, until you get there. Um, but again, that safe environment, right? That's that basic level of Maslow's. And so when we're looking at creating that safe environment, right, you may need to recognize or recommend things like, putting bars up in the shower or decluttering, removing throw rugs, right? So we have to be non-judgmental, right? And I don't judge people for having issues, and that's not my mom was a hoarder, so I can understand that, but our goal is for the safety and making sure that they're getting the appropriate care. And I'm one of those people that if I see a mess, I would just want to help and I want to clean it up. Like I can just see myself going in a rabbit hole, not only would I be providing nursing care, but I would be doing housekeeping services and other things too. So, and then I feel would definitely be an invasion of their privacy. And it's not because it's just because I want to help, and that's really what it is. Um, but yeah, I don't know. I thought about it. I would personally think as I get older, I really am becoming more interested in hospice care. Um, and so a lot of hospice care is offered in the homes. Although I will tell you something, and we are going to talk about hospice, I think. I don't know if it's next, but I'll save that story. I'm gonna save my hospice story because this one kind of made me like, what? Other types of care. We have community health nursing. The goal there is to improve the health status of communities or groups through education, screening, and care outside of healthcare or outside of the acute care setting. So this could be like, your health department, working with the health department. We are going to work with people and groups on prevention and modification of health issues. So advocating, caregiving, case finding, health planning. These are also going to fall into your occupational health nurses, your school nurses, those kinds of things. Um, so lots of different things that can be offered through community health. Adult daycare. Now these are amazing. These are amazing. So, adult daycare centers, these are for people who need supervision due to physical or safety needs, but they're not nursing home candidates. So, let's say you're taking care of mom or grandma, okay? And mom and grandma or grandma can't really get along by herself. Like she's living with you and you come home from work, you cook her dinner, you get her ready and go to bed. But during the day, maybe she's not, able to get up and cook for herself, or for maybe she's got some early dementia and she's not really safe to stay home by herself alone during the day. This is what adult daycare centers are there for. So again, it's for, for people that have paid, people that are caring for them during the evening and on weekends, but need somebody during the day. And they offer so many services. I mean, everyone's probably a little bit different, but they get socialization, they got mental stimulation, they can get some assistance with ADLs. Some of them even offer transportation. So the little like buses that drive around will pick them up and then bring them home in the evenings. But again, it's a nice, safe environment. They'll get fed while they're there. And then there's one I know of, they actually even have providers on site. So they have like a primary provider on site so that if something happens or there's, they can just see their primary provider. And of course, that provider can make referrals if needed as well. But these are really awesome things. Um, so I thought those are pretty cool too. We do have residential care homes as well, those for occasional mild cognitive or mobility issues. Some residential care homes, um, they kind of just a little bit different. Um, they will offer either temporary or long-term housing. They offer housekeeping and personal care, but it's generally a small group of people. So like my neighbor in Virginia, she lived across the street from us. When we first moved there, like 30 years ago, she owned a medical transportation business. So she had like vans and all that stuff. And then probably about 10 years ago, maybe a little bit longer, um, she bought a couple houses in the neighborhood and turned them into residential care homes. And so there's like three or four people that live in the home. They have, 24-hour staffing. So I'm not sure. I never asked her how she staffs them, like who staffs them. But they are staffed. She also has someone that, like, if they have doctor's appointment or something else, that will take them to their appointment. So it depends on the residential care home as to what services they'll provide. Your continuing care, retirement, or community, these are really cool too. Um, they offer continuum of care from independent to skilled nursing care. So, for example, it's like most of the ones that I've seen, some of them are like they're completely separate buildings in different areas. And then a couple of the other ones I've seen, they're actually just big like campuses where they have like, well, not a few, but a bunch of acres. So like you'll have your assisted living on one or your independent living apartments, right? Where, it's generally, 55 plus, right? Community. They live in their individual apartments. And then maybe if they have a decline in function, they can go to the other side of the campus and they may have assisted living where they'll get a little bit of assistance with their ADLs, but not 24-hour nursing care. And then, or, let's say maybe they fell and they broke a hip and now they need rehab. Then on that same campus, they may have that skilled nursing home or that skilled care facility or the long-term care facility. So it's kind of all like in some cases, it's all on the same campus. Other companies that I've seen, they've had like assisted living or independent living in one area, assisted in another, but most of the assisted livings were attached to a long-term care facility. So it was still a continuum of care. So it's just interesting how they do it. Where's okay. ROOPS, rehab services. So we have really already talked about this a little bit. They focus on return to function, prevent further disability. So again, when somebody has a heart attack, a stroke, a hip replacement, a knee replacement, any of those wonderful things, they're going to need some rehab, right, to get back, get their muscle strength back, in some cases, learn how to do things differently with that OT services. So We have rehab services. Where's, individual rehab centers like we were talking about earlier, they have special where they're either specialty hospital or sometimes they're called like acute rehab hospital. A lot of times it's located within a skilled care, or I'm sorry, a long-term care facility. They'll have a long-term care side and then they'll have an acute care side, or in depending on how it's set up, if it's just one unit, then they kind of just intermingle within the long-term care. There are outpatient facilities, there's the residential homes, and of course we can do this in home health as well. Rehab services can be offered pretty much anywhere. Wellness centers, another little another thing that is offered as well. So wellness centers, these focus more on promoting wellness and detecting diseases in early stages because we know the earlier we find something or detect something, it's easier to treat, it's less expensive to treat, and a lot of times, if we catch it early, we prevent the decline. But these are things like the nutritional counseling, exercise programs, stress reduction, and weight control. Some insurance companies as well. I think Medicare does. I don't know if it's Medicare or one of like the what do you call them? Like the brain just went blank. One of the insurance companies that offers Medicare services, sorry, sometimes they'll pay for you for like them to have like a membership to like one of the gyms where they can get the counseling and the exercise and things like that. Sometimes the other programs like Weight Watchers, smoking cessation, parenting classes. So there's a variety of different places that will offer these things. Some are free first, some are free services. Others, may have to pay for some of the services. But some, again, like I said, some insurances also will pay for this as well. So this is hospice. I knew it was like, I think hospice is here too. So hospice care, the philosophy is hospice is to maintain comfort as death approaches, or what we call death with dignity. Um, it is available to people who have been certified as terminally ill, generally meaning that they have a prognosis of 6 months or less to live if the disease runs its normal course. And I say that because sometimes the disease doesn't run a normal, course. And I've known patients that have been in hospice care for a couple years, okay? I've also seen patients that get admitted to hospice on a Monday and they pass by Wednesday. So it just depends, right? But generally speaking, rule of thumb, they have to have a diagnosis of six or a prognosis of 6 months or less. Hospice can be provided anywhere. It can be provided in a hospital. It can be provided in a long-term care facility, in a skilled care facility, at home. There's also hospice houses. Now, this really is going to be the person's preference, right? Some people want to die at home where they're comfortable, they're surrounded by their stuff, their families. Other people don't want to die in their home, right? Because of either personal or spiritual beliefs. So they can be offered in other places. Um, so the facility that I work at, I work skilled care, so I deal with the hips and the knees and the hearts and the IV antibiotics and all that. And I was talking because I'm new to Texas. I mean, well, not new. I guess I've been there a year and a half, but still feel new to Texas. I was talking to the pharmacist one night. This was when I first started. I was trying to figure out because we did have a hospice patient and I didn't I was still learning, so I didn't know what the process was for the hospice medications. Like, do I order the hospice medications specifically through hospice? Like, it was a whole big thing. So he was telling me, um, there's one, and I don't know which hospice company it is, but one of the hospice companies where I live, they actually rent a like three or four, I don't know if it's rent, is that the right word? But they have three or four hotel rooms that they use for hospice. Yes, and I was like, wait, what? He was like, yeah, so the hospice agency has like these three or four rooms, he said. I guess that's like their hospice house. Because he's like, I've actually had to deliver the hospice medications directly to like the hotel. And I'm like, I had never heard of that before. Like that was something that was completely new for me. Like, yeah, I am not a hospice nurse. I have had hospice patients because hospice nurses don't spend 24 hours with their 24 hours a day with their patients. So I've worked with hospice patients before, but that was the first time that I had ever heard that. I was like, interesting. So I was like, what hotel is that? Because I don't want to go. I don't want to go now. I'm not going to spend the night in that hotel. It's very haunted. Um, sorry. Yeah, just it. But yeah, but hospice care can be provided anywhere. Again, it basically is, whatever the patient's preference is. Um, Hospice home care, again, they want to die in their own home. And hospice is there's always going to be an RN case manager, but it's LPNs, it's home health aides, CNAs. A lot of times they'll have volunteers as well. Um, Clergy or what's the it's not clergy, it's oh my gosh, chaplains. They'll have chaplain services. So variety of services. There is always a medical, like a doctor, nurse practitioner available on staff as well, should, additional orders and things be needed. But again, hospice can be provided in pretty much anywhere. Um, Palliative care is a little bit different from hospice, okay? So palliative care provides comfort care. All right. It is very similar to hospice care, but it is different. So, um, palliative care is initiated at the onset of treatment and can be accessed at any stage in an illness. So for example, let's say a patient is diagnosed with cancer, okay? And they're not in hospice care, but they're getting chemotherapy, they're getting radiation. And you guys know from pharmacology, right? Chemo has a whole bunch of nasty side effects that can be caused. And so we can put them in palliative care. All right, so it's care that can be accessed at any point in the illness, whether they are terminal or not. So, IV fluids, oxygen, tube feedings, those are all examples of palliative care, right? If I have um, okay, here's one. Let's say I go and I have to have a surgery and I have post-op nausea and vomiting and they give me IV fluids and antiemetics. Guess what? That's an example of palliative care, right? We're trying to relieve symptoms. Um, so I can, receive palliative care, still get life-saving implementations. Okay. So not all palliative care is hospice. Okay. But hospice clients can also receive palliative care, right? There's nothing saying that a hospice patient can't have tube feedings, that they can't have, IV fluids, that they can't have oxygen, right? We're providing palliative care to hospice patients, but anybody can have palliative care depending on what is going on with them. Um, and so again, it just helps to improve the quality of life of patients and their families by relieving those symptoms and stress of a serious or debilitating illness. So, things to relieve symptoms of loss of appetite. Like I said, we can do G tubes, PEG tubes, NG tubes. Pain, obviously, we don't want nobody should be in pain, right? Pain is always something that we are going to try to treat. Nausea, sleeplessness, We can also provide help with healthcare decision making as well as supporting family members, right? So there's lots of different things that we can use in palliative care. So again, just remember, okay, that not all palliative care is hospice, but hospice clients do receive palliative care. Um, yeah, so moving to Texas, it's just so different. Um, there's lots of different things. Like I learned that about hospice, urgent cares. I thought this was another big change for me. I don't know how it is in Ohio or, but like in Virginia, in the area that I lived in, maybe within a 10-mile radius, I had maybe maybe three urgent cares, okay, in a hospital, right, with an emergency room. In Texas, there's urgent care on every corner. And I'm not exaggerating. I'm not lying. Like, you know how you have little strip malls, like, you have a nail salon, you'll have a pizza place or whatever, and then there'll be an urgent care. Like, they're just like everywhere. It's just so different for me. So yeah, so availability is a little bit different. Like, there is no shortage of urgent cares or dentists in my area within like a 2 mile like radius or yeah, radius of my house. There's probably like 10 different dentists and like about 5 or 6 different urgent cares that I can go to. And I had to go. I had to go to urgent care and I was literally in and out with under an hour. I was like, this is amazing. Like, and you can think about it, you just have to drive, right? If that parking lot looks full, you can just drive to the next corner and see what that parking lot looks like. That was just it. So it's a lot different. It's a lot different from what I was used to. It is a much higher population down there than where I was in Virginia too. So that could be part of the reason why I'm seeing so many changes, but I was just like, and hospitals are like literally across the street from each other. So you'll have like one hospital, like Baptist Health is really big. So they'll have like a Baptist hospital, and then across the street, there's a Methodist hospital. And I'm like, where do you go? Like what's the difference? So yeah, it's just kind of crazy. I don't know, like I said, I don't know what it's like. I've never been to Ohio. I've driven through to go to Illinois, but I have never been to Ohio. But I just think it's funny how you go from one area to the next, right? And you can see the different things that are offered. And it's so different, right? In a lot of cases. All right. Does anybody have any questions? You guys are good. All right, you ready for take a break? All right, be back at 3:20. Okay, guys, I am so sorry. My apologies, 100,000%. Um, I'm in Virginia right now. So my daughter had an accident. She is okay. But she punctured her eyeball. So her eyeball like everything, like it deflated basically is I guess. I don't know, not an eye, like I'm not neuro or anything like that. I'm not 100% the correct terminology for all of that. But yeah, so anyway, she called me because she was having some weird drainage, and I was like, because I brought my younger son and I are here together, so I'm working. He's over there with her, so I told him to take her to the doctor. So I was just trying like navigate that real quick. I apologize. All right. So for the next chapter. So chapter 17, I think it's no, 16, sorry. So chapter 16 is about healthcare settings. I mean, sorry, healthcare systems. Okay. Basically, how do we pay for healthcare? So talked about the settings and where we can have our healthcare performed. And now we're going to talk about basically how do we pay for healthcare. So we'll share. All right. So healthcare system. So this is a very accurate statement. Okay. So the U.S. healthcare system has been described as a poorly organized and complicated maze of services which lacks preventive care, wastes resources, and is very expensive. Nothing untrue about that statement whatsoever. If anybody has ever had to be has any used any healthcare services in any form, you know that it can be a complicated maze. Um, Historical trends kind of assist in understanding how that occurred. So Medicare back in the 1960s and the early 1960s before me, healthcare providers' key role in healthcare decision making combined with fee for service, payment combined to healthcare costs, and we didn't pay a whole lot of attention to cost containment. So what does that mean? So I'm the doctor, right? And if you have a splinter in your finger, I'm going to order x-ray, I'm going to order a CT and MRI, right? I'm going to order all these tests, and that's a little extravagant, okay? But I'm just using that as an example, right? I could basically order whatever tests I want. There was no control. There was no control over any kind of cost containment, unnecessary services. Um, they just kind of did what they wanted to do, and we had to pay for it, right? So whether, and a lot of times, a lot of people back then, they were private pay. They paid out of pocket for healthcare services. So it just kind of got out of control. And so in the early 1980s, like you see here, Medicare, they changed from a fee for service payment model to what we call a prospective payment system based on DRGs. And then Medicare kind of sets the standard for other insurance companies. So when they set that standard, other insurance companies started to follow. And we will talk more about DRGs but PPS, that prospective payment system, that is what those DRGs are based on. So basically, the hospital was paid for the client based on the DRG. And the DRG is just the diagnosis. You come in with a heart attack, an asthma attack, a broken hip, whatever it is. It has a specific DRG, and you get reimbursed based off of that. The goal here was it focused on minimizing the length of stay. Um, and this is where we had like the development of that utilization management. Um, and then the payment eventually extended to include your healthcare provider payment, which led, like I said, to the managed care organizations, preferred provider organizations, what is it, point of service, and other types of plans kind of opened up from there. Managed care organizations, they provide the delivery and the financing. Okay, so MCOs is that term. They provide for delivery, and that's your HMOs or your PPOs. So, how do you know? So, if you have insurance, whether it's through your employer or even through the marketplace or wherever, um, you should, on your insurance card, it should tell you if you have an HMO, a PPO, or a point of service plan. Um, so it kind of gives you an idea of like what type of health plan you have. So, what has changed? Um, I want to say a lot, but we've had a small improvement, okay, in healthcare costs. But we still, right, we still have increase in costs. We still have inequities in access to healthcare. Um, we not all have access to healthcare. So that means that if I don't have access to healthcare, then I'm not getting my screening and my preventative services, right? And that's a huge issue because, again, we want to screen, we want to prevent, and we want to catch things early to prevent those costs from being more as they go. So a lot of people think the healthcare system is just broken, and it's not that. They're not trying to not fix it. So they are doing some stuff. So everybody has heard of, the Affordable Care Act. A lot of people refer to this as Obamacare because President Obama, President Obama was the one that initiated the Affordable Care Act. But when was the Affordable Care Act? Does anybody remember what year was it? Was it 2014? No. Was it 2014? Was it really that? I don't remember what year it was. But think about that. How crazy is it? Even if it was, let's say it was 20, I think it was 2014, 2012, somewhere around there. But that was the first piece of legislation to address healthcare reforms in the US since 1965, since before I was born, when Medicare was added to the Social Security Act. So that's crazy. It went all those years. Nobody really paid a whole lot of attention to it. So the program was designed to enhance access and affordability of healthcare, particularly to all citizens in financial needs in the United States. Did it do everything that we hoped it would do? No. But did it make a huge difference and had a lot of positive change? Absolutely did. It also established the health insurance marketplace. So I don't know if anybody knows about the health insurance marketplace, but that is for people that don't have group life or group health insurance through their employers, or they're not eligible for Medicaid and they need to have personal health insurance. The that marketplace, it helps people to, with low to moderate income, it helps find resources for payment. It helps them pick and a plan that they can afford that will help them. It eliminated lifetime coverage limits. So this is another one, and I'm gonna tell you, it wasn't until then that I ever really understood, like, and not understood it, that I ever really looked at this. Okay, so and I had to take a step back, and I was like, wow, I never realized this lifetime coverage. So, back in the day, baby boomer generation, lost generation, those generations, they worked for a company for 20 years, maybe sometimes more, right? They retired, they had a pension, right? They had all that. So I can see my generation, now we're pretty stable, but we still, a lot of us didn't stay in that same job for 20 years, but you get your insurance. You sign up for your insurance, okay? Maybe it's just you, maybe it's you, your spouse, your children, whatever it is. There used to be a lifetime coverage limit. Now, I don't remember how much the limits were. Like, I don't know if it was like up in like 100,000 or if it was like 60,000 or 50,000, whatever it is. But you used to have a limit on the amount of certain, like on it had a monetary cap on the amount that the insurance would pay over a lifetime. So I thought that was pretty interesting. So I'm glad that that got put away because that would have been, think about it. You have, especially think about some of these people that have like special needs kids and other, or even serious, health issues that require continuous care, right? They may reach that cap. It reduced prescription drug costs for Medicare beneficiaries. It also pre-existing conditions are covered. So also, in addition, what would happen is, let's say you had diabetes or hypertension, you're pregnant, okay, and you leave your job, because you get a better job or you get a different job, you move and you sign up for your insurance. They would have a lockout period where they won't cover pre-existing conditions. So if you had a chronic disease, hypertension, diabetes, you're pregnant, that lockout period, you can't get care unless you're paying for it yourself because it's a pre-existing condition. So
That
got rid of that. Go ahead.
that still happens. So my wife has heart failure, and Walmart changed their health insurance companies.
Mm-hmm.
And she got a piece of paper in the mail saying that she is denied service through the new health insurance. So she called and they said, "Well, you're not diagnosed. How do you know you have heart failure?" And she goes, "I've had heart failure for 3 years and I have an ICD." She goes, and the lady was like, "You're not authorized that procedure." So she was like, this was 3 years ago. How you guys
Right.
have my medical information if you took over the insurance policies?" So
Mm-hmm.
that was a thing that we had to go through for a couple of weeks. Um, they wanted us to prove that she had heart failure, how sick she was, what medication she was on, and that if she was actually needed an ICD.
What?
Yeah, so you have a company who employs, you know, majority of the population of the workforce, 1.5 million people paying into insurance. How can we not have better insurance coverage?
Right. That's crazy. Yeah, they're not supposed to deny you that care.
Yeah, she pays $75 every time she goes to the doctor. My sons, twins, they both have heart failure, also, same condition, everything else. They work for the hospital, the local hospital. Every time they go to the doctor, they only have to pay the copay of $25.
Mm-hmm.
And so I keep telling her she just needs to quit Walmart and go to the hospital where she'll have better care, better coverage.
Mm-hmm.
Everything's so much better while you're somewhere else, it seems.
And that's interesting though, because as big as, like you said, as big as Walmart is, you would think that they would offer better services to their employees. It's not like we're talking about like a little mom and pop shop, right? That, may be limited on their income, but wow. But yeah, those pre-existing, because my cousin, we're 6 months apart. She was diagnosed with diabetes. She has type 1 diabetes. She was diagnosed as a baby. And there were a couple times that like twice that I remember that she had switched jobs. And it was the same thing. They gave her they, wouldn't cover her insulin. They wouldn't cover the supplies. Like it was a big deal. And this was one of the goals of the Affordable Care Act was so that people did not have to go through that. Now, my daughter, she switched jobs after, or yeah, she switched jobs. When she switched jobs, she was pregnant. And when she applied for her short short-term disability for her maternity leave, they tried to say it was a pre-existing condition that they weren't going to pay. Like she was pregnant, like what, I don't, yeah, I don't understand. I did work for an insurance company for a little bit of time, but I also worked for TRICARE, which is the military insurance. So it doesn't matter. Like even back when I worked for them, it didn't matter if you had a pre-existing condition or not. Everything was covered, as long as it was within policy, it would be covered. But yeah, like I said, that was supposed to be one of the big things with that. Um, the other one that it did was, wow, um, it allowed the states to determine Medicaid eligibility requirements. So this is why, like, if you're in Ohio and you're eligible for Medicaid, but you decide to move to Pennsylvania or I don't know, Ohio, sorry, Illinois or, West Virginia, wherever, you may not meet the eligibility requirements for that state because each state does determine their own Medicaid eligibility requirements. Other things, when we look at other ways to finance healthcare, we have fee for service. Fee for service, this was the traditional method. Okay. Um, I whatever the fishes, the doctors were paid a fee for whatever service they provide. So, this was, like I said, this was traditional. If you go into the doctor's office, you see the doctor, so you get the physician charged his fee. Let's say you had strep throat and they did a strep test, right? They're going to charge you for the strep test, whatever services. So basically, again, whatever services they provide, they were typically reimbursed for most ordered diagnostic tests, treatments for illnesses. Some insurance companies will not reimburse they do not reimburse for preventative or diagnostic tests for early stage illnesses. We are starting to see a shift in that now, where a lot more preventative measures are now being approved a little bit easier. Capitation involves healthcare providers receiving a fee per member over designated time frame. So this this one to me is always a little bit confusing. So let's say you have ABC Healthcare, okay? And you can choose from, the list of providers that they give you, and you sign up with Dr. Smith, okay? So Dr. Smith is going to get a monthly fee. Or he's going to receive a monthly fee for each member of the insurance group for a specific set of services. It sounds kind of crazy, right? But whatever services that he provides during that month. And so let's say, everything is good, don't really need anything. And then all of a sudden, I don't know, something happens, person gets sick, and we have to use, a little bit more services. So anything over that monthly fee, the physician's going to have to cover that cost. All right. The goal is to keep members healthy for the patient, for the provider to make money, basically, is what happens. I think of this kind of like car insurance. Okay. We pay our car insurance every month, right? It goes, and those insurance companies, they have all our money, right? How often do we use our car insurance? Hopefully never, knock on wood, right? But we pay all this money to have car insurance, praying that we never have to use it, right? So that's just profit for the insurance company, right? That's just profit for them. That's kind of like what this is, except, they're still going to provide some services to help keep those patients well. Now, some of us do have, well, I was going to say, I don't even use those either. I was like, a lot of people get like roadside assistance, right? With their car insurance. And maybe you need to use that every once in a while, if flat tires happen, whatever, right? But still not really getting reimbursed for the amount of money that you're paying in, and then you still have deductibles, right? That, something does happen that you have to pay. Um, and then we have personal pay. Personal payment. This was the primary method before the 1940s. Again, you went to the doctor, you had strep throat, you had to pay the doctor for, his services as well as, any medication that he gave you. Um, I couldn't imagine, back in 1940s, it was expensive, but based on what, the average pay was back then, could you imagine having to go to the doctor's office now and just paying whatever that fee is? Um, what was it? My son went to the doctor. It was like, he doesn't get sick very often. When he gets sick, he usually just gets sick. I think he had the flu. So he went in, he had a flu test and a doctor's visit, and it was $300 that we had to pay out of pocket for a flu test. And no, he didn't even get any medicine. So I can imagine, not alone, but about, a hospital visit or something along those lines would be crazy expensive. Which brings us to our health insurance. So, private health insurance, right? The Everybody pays into it, it's a big pool of money. The goal is to get protection from financial disaster because of healthcare bills, because we know that services provided are extremely expensive, and usually come at a very inconvenient time, and a lot of people don't have the money to just pay out of pocket for healthcare services. Most employers offer your health insurance. So most people have the availability to get health insurance through their employer. Not always the most financial, what's the word I'm looking for? Sometimes it's not always the best option. Sometimes the marketplace may have cheaper options. But the Affordable Care Act does impose penalties for larger employees that do not provide insurance. I think it's greater than 50 employees, they are required to provide health insurance. For the smaller companies, so if they have employees less than 50, then they get like subsidy, is it like a subsidy or something like that, um, for providing health insurance. So that's a little bit, yeah, they get a tax credit. That's what it is. They get a tax credit if they do provide health insurance. So examples would be like your Blue Cross, your Blue Shield, your United Healthcare, Cigna. Trying to think, I don't know any other ones off the top of my head, but those are just some examples. Your private non-group health insurance, these are offered by insurance companies to individuals who are not part of a group. Premiums are based on your health risks and your age. So again, you can do this either through like the healthcare marketplace, or let's say you really like United Healthcare. Maybe you can call, United Healthcare may offer non-group health insurance. And so they would base how much your premium was based off of your age, and your health risk. Oops. Okay, this is another one. This is really important to understand, especially if you've never had to deal with insurance before. So these are the terms. So the premium is the monthly fee that you pay just to have insurance, like your car insurance, right? Whatever your car insurance is, whether it's Allstate, State Farm, Farmers, the General, whoever it is, right? You pay them that monthly fee. That's your premium. Okay, that's how much you have to pay. Most employers will take it out like with each check. So like half in one check, half in another, whatever it is. But that's your monthly fee. And it's important to note this because depending on how they word it, when you're getting a new job, you have to read, is it a monthly fee or is it a biweekly fee? Because I've seen some where they try to slip it in, it looks like it's monthly, but it's actually biweekly. So make sure you read that. Um, your deductible is how much you have to pay out of pocket before your health insurance will begin to pay. This is another one. Um, so deductibles can be $1,000, they can be 2,000, they can be 3,000. It depends. Usually with insurance, there's different tiers that you can sign up for, but you need to pay attention to your premium as well as your deductible. Because you have to meet that deductible. So basically what that deductible says, so I'm not only am I paying my premium, okay, but now I'm gonna have to pay an additional $1,000 before my health insurance is going to kick in. Your co-payments, those are what you pay at the time of an office visit when you're picking up prescription or for hospital services. So those are often different. So like Victor was saying, his wife has to pay like $75 to go to the doctor. Okay. It is also should be very available to you when you choose your insurance. So there's different levels there as well. So you may have one copay for your primary care provider. You'll have usually a little bit more expensive copay for a specialty provider. And then for urgent care or ER, and there's a different deductible, and all of that should be laid out for you. And then co-insurance. This is once you paid your deductible. Doesn't mean that they're going to cover 100%. That just means they're going to start paying. All right. And so once your deductible met, the co-insurance is the percentage of the bill that you are going to be required to pay. So, is it the insurance company pays 80%, you pay 20%? Is it 60/40? Like, what is that? So these are really important things to look at when you are getting ready or when you're educating your patients on choosing insurance plans, because it's not cut and dry. There's a lot of different factors that come into play and really understanding. And I will tell you I married I was military and married another military person. So we dealt with military insurance, right, for, 20 years. So it wasn't until he retired from the military, and he got, a job and I never had insurance because I always had the military insurance. And the first time we had to choose insurance, I made a mistake. I did not look at any of this because I didn't understand it. And we struggled for a year because we had 4 kids and it was a lot. So, it does help to understand. It really helps you. You can't always calculate how much you're going to spend out of pocket, really, honestly, because, especially if you have kids, stuff happens, right? They have accidents, they get sick, they have injuries, so you can't always, but really understanding, at least looking at the numbers and knowing what they mean is very helpful. And it's helpful when you explain it to people because you would be surprised how many people still, they don't understand. So you may, and I've actually had to explain Medicare to some of my clients because they don't understand how it works either. And that brings us to our public health insurance. So public health insurance, this is your Medicare, your Medicaid, and your Veterans and Health Administration. So I'll make this a little bigger. All right. So Medicare is a program of Social Security. It was added to the Social Security Act in 1965. It is an entitlement program, okay, and a public health insurance plan. So it helps to finance healthcare for patients that are people over the age of 65 and their spouses. Again, it is a federally sponsored entitlement program. So you're only automatically guaranteed Medicare if you have paid at least 10 years in Medicare covered employment, you are a citizen or permanent resident of the United States. Okay. Otherwise, because like for my example, my sister, she was a stay-at-home mom. She never worked outside the home, and so she never paid into Medicare. So she's not eligible for Medicare when she gets older. So, there's, things like that that you have to like kind of look at. So you have to pay in for 10 years and you have to be a citizen or a permanent resident. We do offer, or they do offer Medicare to some younger patients that have disabilities. Patients with end-stage renal disease also are eligible for Medicare as well. And with Medicare, no one can be denied. If you are eligible for the entitlement program, you cannot be denied coverage, okay, based on your past medical history. So it doesn't matter what's in your past, you are not denied coverage at all. So with Medicare, there are different plans that are going to fall under here. Okay, so Medicare Part A, that is your hospital insurance for inpatient hospital care. All right, so it covers your hospital stays. It will cover care in a skilled nursing facility. It'll cover hospice. It may cover some home health care as well. Medicare Part B, this is your regular health insurance. So it's the medical insurance for your doctor's visits, your outpatient care, your diagnostic tests. It also pays for mental health services. Sorry, there's a net. It'll pay for ambulance transportation, some diabetic supplies, your PTOT, speech. It'll also pay for some preventative care. So anything that you would get basically at a primary healthcare provider. Neither A nor B cover prescription. They do not cover prescriptions, so your medications are not covered. None of them cover dental care, dentures, hearing aids, eye exams, glasses, contacts, none of that stuff. Although I did see somewhere where some insurance companies are actually starting to cover hearing aids. I haven't done any research into that, so I'm not 100% sure. So you get Medicare A is the entitlement program. Okay, so you get that. That's what you get, and then you can add Medicare Part B to your Medicare plan. Part C is completely different. Part C is what we call a Medicare Advantage plan. All right, so the government sponsors Medicare A and Medicare B. Medicare Part C are offered by private companies that contract with Medicare. And so these companies will offer things that straight up Medicare does not, like your prescription drug coverage and other types of coverage. They also, there's like, you can get like what is it called? Like the FSA, what is it, the savings account, like you can put money in, so like you get a card like to pay for like deductibles and stuff. Savings, oh my gosh, I can't remember what it's called. That's kind of similar. So there's a medical savings account, but it's different. It's not offered by Medicare. It is an outside company. Medicare into Part D now is the prescription drug coverage. So it is offered through Medicare itself, or it is offered through other companies that partner with Medicare. So Medicare A, that's that's your guaranteed entitlement. You have to pay for Medicare Part B. That's an additional coverage. And then you can either choose Medicare Part D or you can choose one of those Medicare Advantage plans. It is completely up to you or up to the person. If the person has Medicare Part D, they can't have Medicare Part C. All right, and vice versa. So if they already have a prescription drug plan, they can't have an additional prescription drug plan. So one or the other. So again, part A, that's your hospital insurance. All right, inpatient hospitals, all the stuff that goes with your hospital, your skilled nursing facilities, some home health, and then Medicare Part B, that's your major health insurance. So your, regular doctor's office visits, your ER visits, mental health, lab x-ray, durable medical equipment. So you need a cane, a walker, a wheelchair, an elevated toilet seat, a bedside commode, whatever, oxygen supplies, kidney supplies, some diabetic supplies. That's all part B. Part C is an advantage plan. So it does offer your prescription drug coverage as well as helping cover some of the costs that Medicare A and B aren't going to cover. And then Medicare Part D is just the prescription drug company. Again, you can't have both. You can't have Part C and Part D. You have to have one or the other. There's also Medigap insurance. And this is the thing. This is what I think blows my mind a little bit is people over 65, they're limited incomes, right? But, you know, they have Medicare, they're eligible for Medicare, but it's not going to cover all their health insurance, all their health needs. And so they end up paying additional money anyway. Medicare or Medigap, this is another out-of-pocket cost. It's purchased to cover items Medicare doesn't cover. Okay, so your deductible is your copay, is your co-insurance, right? It'll fill in those gaps. And this is what I was saying earlier. You can enroll in Part C and Part D if you have a Medicare Advantage plan that includes prescription drug covers and you join a Medicare prescription plan Part D, you'll be unenrolled from Part C. So why I don't know, because to me, that's just trying to limit the amount of out-of-pocket costs that they have, but then it's not, it can't be done. It's not allowed. On the other side of this, we have Medicaid. Okay, so Medicaid was also added to the Social Security Act in 1965. It provides medical assistance for eligible families and people with low incomes and resources. So you must meet the eligibility requirements. Um, Medicaid is a cooperative venture, so it's jointly funded by the state and the feds. So the state is who identifies what their Medicaid requirements are, their Medicaid eligibility is. So the federal government is very broad in its guidelines. Each state, right, determines its own eligibility. That's why I was saying if you live in Ohio and you're eligible for Medicaid, but you move to, Pennsylvania, you may not meet the eligibility requirements in Pennsylvania. So be mindful of that. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. So you have to have been here for at least 5 years in order for to be eligible for Medicaid. CHIP, which is the Children's Health Insurance Program, is a program under Medicaid. It provides medical assistance for eligible children. So it covers uninsured children up to the income guidelines. So, and it's for your low-cost health insurance for kids up to age 19. CHIP is a great program. When I worked in PEDS, I worked a lot with the Children's Health Insurance Program. It's an amazing program, especially for low income families, because it covers everything for those kids. So sometimes, I had some parents who would, they complained a little bit about like the application process and it was a little like rough, but it's a great program for kids. Like some of this stuff like I didn't realize that they covered. Parents would call in for like different things and then be like, I don't know if that's covered under your insurance. And they're like, oh yeah, it is. And so it is a really good program. Cost of health insurance. So I mean, I've talked about the premiums, the co-insurances, the deductibles, all of those things. Um, the premiums go up every year. Like I don't know if anybody has ever like really looked to see what their health insurance was costing them. Premiums go up every year. However, the Affordable Care Act does require the government to create a process in conjunction with the states where insurance they have to verify or justify any unreasonable premium increases. And I don't know what they consider unreasonable, but if there's an unusually high increase in their premium, they have to justify it. And well, then that brings us to the uninsured, but I do need to give you a break. Be back at 4:15. All right, so let's talk about our uninsured. So the uninsured often includes our low-wage employees. So people that are employed in low-wage jobs that are less likely to offer insurance benefits, and the middle class. Some of these workers in the middle class are unemployed, but those employed may be priced out of the health insurance market because of the insurance premiums being so expensive. So let's say, like you work, what is it? I'll just say let's say you make $20 an hour. Okay, that's about what, $800 a week, right? If you work a 40-hour week, so that's $800 a week. So 1,600 every 2 weeks. But if your health insurance is, $500 or $600, right, then that could price you out. It's generally more expensive too. If you're married, you have kids, right? Your health insurance premium is going to be a little high. And so then, how are you going to pay for food and your car and your grocery or your rent or your mortgage and other things? So generally speaking, that's, the people that are more likely to be uninsured because they can't afford to have that money taken out of their checks every week or every 2 weeks, depending on how it's set up through the company. So we have alternatives. Medicaid, of course, if they qualify for Medicaid, then, obviously they can get Medicaid. If they can afford to pay for it out of pocket, they can, pay out of pocket. Some places do offer charity care. We talked a little bit about like free health clinics and things like that if they qualify for those. Charity care, or even, if you have to call and negotiate your hospital bill, right? There may be some charity care that may be available, or sometimes face medical bankruptcy. So I remember a time way back when, um, if you had medical bills and you didn't pay your medical bills, it didn't affect your credit score, and a lot of people ended up, just not paying their medical bills because it didn't really affect them. Now it does, right? Now it does affect your credit score. Everything gets reported now. So really have to, find a way to assist these people in paying for their medical bills. If you don't have access to healthcare, whether it's because of, lack of insurance or even location, right? Think of some of those people in those rural areas. It prevents people from getting preventative care and then seeking treatment when a health problem is developing. Okay, so that results in a delay of care. We're not recognizing, identifying issues early, which in the long run, it's going to lead to higher medical costs, right? Many people rely on emergency departments for all levels of healthcare because they don't have insurance and they don't have that healthcare provider. So they end up using the emergency room when stuff happens. Emergency room treatment is extremely expensive. And we know that the emergency room is more for those seriously ill, critically ill people. It's, not for the less serious illnesses, but because they don't have the access, that is what they end up doing. So this payment system, so we talked about this a little bit at the beginning. So the prospective payment system is a system of reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide care. So again, it's based on that DRG, that diagnosis readiness group. So let's say a patient comes in because they're having a heart attack, okay? That hospital knows exactly how much because it's predetermined. So the hospital is going to know exactly how much money they are going to receive from the insurance company to care for that patient with that heart attack. Now, most people will have more than one DRG, right? Because there's usually multiple things that are going on, but it is a fixed amount. The payment amount for the service is based on, again, that DRG, and the hospital knows in advance. And it just provides a financial incentive for hospitals to control cost and cost containment. It's a way to make sure that we're not duplicating services, we're not offering, we're not doing unnecessary tests, It's just, again, they know exactly how much they're going to get paid based off of that DRG. So, either they stay under the amount. If they go over, they're not getting reimbursed, right? They're still only going to get that same amount. Oops. So here's that DRG again. Again, it's predetermined payment schedule under that prospective payment system for the treatment of specific patient conditions. Um, the flat fee depends on the DRG category, causing the client's hospitalization, regardless of how long they end up staying in the hospital. Doesn't matter. They're going to get that flat fee. So hospitals have that incentive to treat clients, discharge them as quickly as possible. What do you think are some issues with that before we go on? What do you think? So the goal here is treat clients and discharge them as quickly as possible. What are some issues can you see with that?
Not getting the full care that was being promised to be paid for.
Okay, not getting the full care. Absolutely. What else? What else do you think can be an issue with that? What about being discharged too early and they go home and they're not ready to go home and now they have to come back to the hospital, so now we have a readmission, and hospitals do get charged. They or they will get, if the patient is readmitted within 30 days of a discharge, they will get a reduced reimbursement. So you can see there's a really fine line, right, between providing the services, payment, making money, and doing what's best for the patients, right? It's become very, I don't know, money driven, I guess would be the appropriate word here. Um, yes, of course, we want to, treat them. We want them. We don't want people to stay in the hospital longer than they need to, but we need to make sure that they stay in as long as they need to make sure that they're stable enough to return to home or wherever it is they're going. Other things, so safety, quality, safety, and cost of healthcare. So when we look at some of the things that we can do, we have continuing or improving quality in healthcare. We have what's called continuous quality improvement. And so CQI is quality by inspecting client outcomes or incidences of harm or mistakes after they had occurred during care. So it looks at preventing problems or adverse events. So, for example, let's say, that there's been an increase in the number of falls, or there's been an increase in the number of pressure areas. And I'm just using those as an example, okay? They're going to get all the, incident reports, investigations. They're going to get them all together. They're going to have a CQI meeting, which you as future nurses may be invited to sit in on CQI committees. And they're going to look and they're going to try to see if there's a pattern. Is there, like for falls, for example, are they happening more so on a certain shift? Is it more on day shift, more on night shift? What time of the day is it happening? Is it happening more during shift change? Right. So they're going to try to identify some of those things and then put interventions in place to prevent them from happening again. We also have the aims of the Institute of Medicine for Improving Quality in Healthcare, and this is known as STEEP. Okay, so STEEP is an acronym. It stands for, I'm going to mess up one of the E's, I guarantee it. So S is for safe, T is for timely, the first E is for effective, the second E is for efficient, the third E is for equitable, and then P is for patient care or client-centered care. So when we look at safety, we want to avoid injuries, basically, right? We want to keep our clients safe. T is for timely, we're trying to reduce waits. We're trying to prevent any harmful delays in care. Effective, providing services that are evidence-based. And then, of course, we don't want to provide services that aren't going to be or aren't going to benefit our patients. Efficient, avoiding waste of equipment, or I'm sorry, avoiding waste of equipment, supplies, things like that. And then equitable, providing care that doesn't vary in quality because of gender, ethnicity, location, socioeconomic status. And then client-centered or patient-centered care. We're just making sure that we're including their preferences, their needs, their values, and ensuring that the client's values guide all of the clinical decisions that are made. Continued competency and continuing education and certification. So one of the biggest things in providing quality healthcare for our patients is making that sure that we can demonstrate competency throughout our career as a nurse. Okay. So graduate from nursing school, you get your nursing license. That licensure considers nurses from all levels, whether it's LPN, associate, bachelor's degree, that you are minimally competent to provide care. Continued competence is completely up to you. It is assumed throughout a career, meaning you are required to maintain continued competence. And this is something that you will have to do throughout your nursing career, is to maintain your skills. Make sure that you are up to date with current practice and what is the current standard of care. There is no set time frame for continued competence. This is something that you have to maintain on a continuous basis. Now, I will say that some places will help you out. They'll do, like, some places do like annual skills fairs where you can go in and practice skills, but that is, something that you have to make sure that you're doing. Certification's another one. So certifications are available to you as an LPN. Things like wound care, IV certification, long-term care certification, or just a couple off the top of my head that LPNs can get certified in. If you continue your education to get your RN, of course, your availability for certifications opens up, your ability to get certifications opens up. Improving safety and healthcare. This is always going to be a big one. Joint Commission National Patient Safety Goals. These are super important to understand. Safety first, right? That's the bottom of the pyramid, right? That's one of our ethical requirements, right? First, do no harm. So the Joint Commission lists the National Patient Safety Goals. And they are different for every area of nursing. So you will have some for the hospital, you'll have some for home care. There's different ones for long-term care. So it really kind of depends on where you're working. But like, just off the top of my head, two patient identifiers is always going to be a big one, right? Always making sure that we're identifying our patients with two patient identifiers. Medication safety is always going to be a big one. And you can turn on the news, you can Google medication errors, and you're going to come up with some infection prevention. Trying to think of what else, fall prevention. All of those are they all, depending on, like I said, they're different depending on where you work, but it is, look at those national patient safety goals. The transition to practice, this is another thing, and I really, really think this is an awesome, awesome thing. So it is an initiative of the NCSBN, which is the National Council for State Boards of Nursing. They're the ones that write the NCLEX. The goal here is to improve the quality and safety of healthcare by improving the new grads' transition to practice. So hospitals may have a transition to practice program. So when you graduate and you get into their field that you're going to work in, it is evidence-based, and it's usually anywhere between 9 to 12 months. But again, it aids you in that transition from student to practicing nurse. I don't know how many organizations actually use, I know a lot of organizations use it. I don't know how many organizations use it. I know they use it in Texas too, because I've seen them come through like through the Texas Board of Nursing and stuff. They talk a lot about transition to practice. So lots of places do offer it. And if you have the opportunity to go into it, it's really a good program. A lot of places, like some places used to do like what was it called? Like a preceptorship or some I forget what the actual some places called it like a residency program. And then they transition from they didn't, they still, like some places still call it a residency program, but they transitioned the model to kind of mirror the NCSBN model. So they're really good. Improving costs of healthcare. Again, this is always going to be something that we need to do. Cost containment, hold costs within fixed limits. So make sure that you're following your facility policies, like with charging for the supplies used in your patient's care. Some have like a supply Pyxis where you go and you have to log into Pyxis and pull supplies for your patients. Just make sure that you know what your facility policy is for charging. Um, and you know, I always say this, and even when I would bring students to clinical, don't go in with unnecessary stuff. If you're going to go and do wound care, you don't need like a big bag of 4x4s, right? Just bring in what you need. Um, you don't need the huge bottle of saline. Bring a little bottle of saline or pour some saline into, a sterile container or something, and then bring it into the room because anything you bring into that patient's room is now that patient's, right? And so you can't bring it out and use it for somebody else. So some cost containment and know what your role is. As far as, everybody can, do things to help cut costs, without being a detriment to patient safety. Some of the quality improvement payment methods, um, pay for performance and never events. So pay for performance is, how do I explain? The basically it rewards hospitals for meeting and exceeding standards of care for specific diagnoses like diabetes, heart attack, pneumonias, heart failure. Um, so, providing that quality care. Never events, those are serious and highly preventable events like your hospital acquired infections, your injuries that result from a fall. Hospitals don't receive reimbursement for never events. Okay, so we need to make sure that we're promoting that safe environment. So, for example, Mr. Smith came in and he had a stroke and he's, you know, going through therapy, you've stabilized him, but he's refusing to get out of bed. He's refusing to be repositioned. Maybe he's giving the nursing staff a hard time and he develops a pressure area. Now, let's say it wasn't preventable, like, let's say it was preventable because, if we had really talked with him and explained to him what was going on, the hospital is not going to get reimbursed for the treatment of that pressure area. If a patient develops a catheter associated urinary tract infection, and that's highly preventable, then the hospital is not going to get reimbursed for that care. So basically, it's quality of care, not quantity of care. So we have to really pay attention and make sure that we're following policies and procedures, that we're doing what we're supposed to do to try to prevent these things. Because if they happen, then the hospital is going to have to eat the cost. So if a person falls and they break a hip while they're in the hospital and then they have to have surgery on that hip, then that's going to be the hospital's responsibility to cover those costs. The insurance is not going to. So we have to be really careful and make sure that we're providing quality care to our clients. Readmission. So like I was telling you earlier, the goal here is to get them well, or as well as we can, get them discharged. If a client or a patient is reimbursed within 30 days of discharge, then that hospital is going to get a reduced payment. All right. So heart attacks, heart failure, pneumonia, COPD, hips, knees, cabbage, if they get released too early and they are readmitted within 30 days, then the hospital gets that reduced. All right. So where the goal here was to improve the transitions in care. So we need to be able to identify early complications and intervening immediately to prevent that readmission. So maybe there, yes, Victor.
Is there a panel who decides or reviews if they were released too early?
I think the insurance company and the medical directors usually will have that review. They'll review. Um, so yeah, but like what there was a case and oh my gosh, I wish I could remember it. I was listening to it where a patient was released too soon from well, not too soon. I'm not going to say they were released too soon. They were released from the hospital. It was a doctor's like vlog or something like that. The patient was released or discharged from the hospital. Something happened. He ended up passing away. And when I think the family like filed a wrongful death suit or something, and when they went back to review, in the review, the nurse, it's always the nurse, right? The nurse failed to notify the doctor of some, I think it was vital sign changes. I really think it was vital sign changes. But in I don't remember the reasoning. I wish I'm going to find it. I have to find the vlog again. But long story short, anything that changes in your client, whether it's, you're going to get to know your patients or your clients. You're going to write, the more you work with them. Now, sometimes in the hospital, it's a little bit different because, you only see them maybe for a few days. But even then, you're going to notice if their blood pressures are trending one way or something else is trending their temperature. So always make sure that, if it's something you need to report it to your supervisor, to the provider, identify these things. Maybe an extra day or two in the hospital might have done that person better, than sending him home. So we just need to be very mindful of that. Um, The aims of, oh, this is steep. It's on your slides. I already talked about that. Talked about your national patient safety goals. I talked about two-person identifiers, medication safety, reducing the risk of infection, reducing the risk of harm from falls, preventing healthcare-associated pressure ulcers. For hospital, it's a little bit similar to patient identifiers always. Effectiveness of communication among caregivers. This is where SBAR would really come into play. Safety or medication safety, reducing the harm associated with clinical alarm systems, reducing healthcare associated infections, identifying safety risks in the client's population, and then a protocol for preventing wrong site, wrong procedure, and wrong person surgery. I've only watched a surgery, but there is a chime out prior to the start of a surgery where everybody stops, they identify the patient, they identify the providers, and they identify the surgery site and what's going to happen. And that's one of the ways they can do to prevent that from happening. Talked about that. Oh, oops, where is it? Alliance. So this last, I can't find, there we go. Alliances. So when we look at restructuring, um, partnership alliances are partnerships among hospitals, clinics, labs, healthcare systems, and physicians. So it just helps for better coordination of care, as well as cost containment because it can help to prevent duplication of services, which is a big part of it. Mergers and acquisitions. This is where larger healthcare systems acquired the smaller systems. I need to get that out of my way. I don't know why it won't move. Let's see. There we go. And then personal plans. So be self-directed, motivated, be a problem solver, identify what needs to be done and do it, collaborate, of course, when necessary, be flexible, identify tasks or protocols that can be done more efficiently, use critical thinking, and be a role model. One thing that you guys are going out, you're going out into healthcare with fresh eyes. And this is such a big deal because you guys, even though you're coming out of school, you'll be able to recognize things like that can be done a little bit more, efficiently, more effectively, safely, because you have fresh eyes. And so that's your opportunity to go in and really make a difference. If you see something that could be done better, more efficiently, and you have the evidence to support that, bring that to your managers, your supervisors. That's how change gets implemented. That's how things get better. And that's what we really need to do with our healthcare system is make it better for us as nurses, better for our clients in regards to safety and care. So you guys have those, like I said, you guys have those fresh eyes. So you guys can go out there and change the world if you wanted to. All right. Any questions? Nope. All right. Well, like I said, keep up the great work. You guys are doing awesome. I'm very proud of you guys. Have a wonderful week, safe weekend, and I will see you next week.
I do have a question.
Okay.
So I'm working on this group project,
Uh-huh.
and I went to the library or whatever